Good evening, everyone. Today's webinar is Uncommon Nerve Blocks for Acute Post-Surgical Pain. Our presenter is Dr. Arun Kalava. Dr. Kalava is double board certified in anesthesiology and pain therapy with fellowship training from Mayo Clinic. He's the chairman and founder of the American Society for Post-Surgical Pain, founder of Tampa Pain MD, and founder of Ultrasound Experts. Dr. Kalava is an international educator in ultrasound-guided regional anesthesia and interventional pain procedures. Dr. Kalava, please take it away.
Thank you, Nick. Welcome, everybody. Thank you for being here. I know some of you are here because you're curious what these nerve blocks are and when you could use them. Some of them want to just build on whatever they have. They're doing really well with their regular blocks and might want to add a few more. So this might be a good presentation. Before we get started with the presentation, I would like to introduce the American Society for Post-Surgical Pain, a very brand new society. Our mission is to provide a platform that encourages dialogue between the anesthesiologists, surgeons, pain physicians, ER physicians, physiatrists, and other advanced practitioners, practice providers. Our vision is to prevent or eliminate development of chronic post-surgical pain. Now we'd ask, why would we need a new society? Well, anesthesiology societies are usually regional anesthesia focused. They talk about acute pain, but very few talk about subacute transitional pain or chronic post-surgical pain. Pain societies focus on spine pain. Surgical societies focus on advancing surgical skills. There is no society as of today that brings all physicians and non-physician providers involved in surgical care of the patient. So we decided we'll start a society that addresses all those things. I wanted to let you know that we have a few workshops that we organize to advance the science and the skill set in managing post-surgical pain. Our next ultrasound-guided regional anesthesia workshops are in September and December of this year. This is a QR code which will take you to the website, or you can go to ultrasoundexperts.org. Similarly, we have a cryoneurolysis workshop. So if you're bored of doing nerve blocks, you want to up the game in your practice, consider doing cryoneurolysis for post-surgical pain. We're the only cryoneurolysis workshop in the United States. So there are a couple of dates, June and October. Last but not the least, we do have the second annual scientific meeting on post-surgical pain scheduled in December of this year in Tampa, Florida. We would love for you to join us. We will be talking a lot about acute pain, subacute, and chronic post-surgical pain. Our website will be postsurgicalpain.org. This is the QR code if you like to scan. I'm just going to give you a second if you like to scan, or just remember postsurgicalpain.org is the website address. We're also welcoming collaborators since it's a new society. We're looking for social media ambassadors, audio-visual content creators and editors, board members, research and publication liaisons, and membership committee chairs. So if you're interested and if you'd like to contribute to the society, you're more than welcome to send us an intent letter with your CV to info@postsurgicalpain.org. Without further ado, we're going to start up on the presentation today. These are the blocks we'll be talking from head to toe. Uncommon head and neck blocks are the first ones. So greater occipital nerve blocks, when would you do them? Well, posterior occipital craniotomies are good indications, occipital scalp lacerations, occipital lipomas and tumor resections as well. So we go over briefly about the anatomy. Again, it comes from the C2, dorsal primary rami. The main muscles for you to remember are your semispinalis capitis, which is superficial, and deep to that is the obliquus capitis inferior. It's going to look like a fascial plane where the nerve passes through the semispinalis capitis muscle and obliquus capitis inferior. So here's the pro position, how you position a little bit oblique towards the transverse process of the atlas. Here's the scanning. We'll be showing you a lot of videos today. So we have muscle 1, muscle 2. Here's the occipital artery. So I'm going medial to find the occipital protuberance. So here's the occipital protuberance. I'm coming down with C2 transverse process because C1 does not. Sorry, so spinous process. And you're back to where you are, muscle 1, muscle 2, and the nerve itself is actually medial to the artery. After you deposit the local anesthetic, the picture could look like this. So let's look at a real life video of this. So you have 2 layers, obliquus, capitis inferior, semispinalis capitis on the top. I usually use nerve stimulator in combination with the ultrasound guidance just to be sure that we do get a twitch in the right area of the distribution of the nerve. So you can either put it in the fascial plane, or you could just do a nerve stimulator plus ultrasound guided procedure. Volume's usually very low, 3 to 5 cc suffices. If you're interested in cryoneurolysis, the cryoneurolysis will look something like this, where you'll see the needle and then the ice ball will be on top of the needle where it's freezing the entire nerve. So we're between semispinalis capitis and obliquus capitis inferior. Again, the ice ball and cryoneurolysis gives pain relief for up to 90 days. So if you want prolonged pain relief for certain reasons, then that's a good indication there. Supraorbital supratrochlear nerves, right in front of the frontal area here. Awake or asleep craniotomy is a good approaches. Frontal lipoma resections and scalp lacerations are. If you look at these nerves, they're actually branches of the frontal nerve, which is a branch of the ophthalmic division, which is a branch of the trigeminal nerve. So they're both together very close to each other. So if you block one, we assume the other also blocked. Here's the scanning technique. You're just on the eyebrow. This is the periosteum. You're going a little more medial. You'll see a supraorbital foramen here. So depositing the medicine here would take care of the nerve block. Here's a procedure picture of how it's done. You can place the probe, patients being prepped. They can be under mild sedation or under anesthesia. Volume's very low, usually 1 to 2 cc suffices. Maxillary nerve block. There's a lot of information here. I think the most common area where maxillary nerve blocks are performed is pediatric cleft lip and palate repairs. Facial fractures can be a good indication as well. So can be transphemoral hypophysectomies. The others are mentioned here, which are a little uncommon. As you know, maxillary nerve has a lot of sensory branches, predominantly sensory. Not going to go over all the branches. We're just going to focus on getting the maxillary nerve block. So sonar anatomy-wise, you would look at the maxilla, which is anechoic and sphenoid, and then you have the pterygopalatine fossa in between. Volume's usually very low. As you can see, this is a modified autoplane approach. You would not see the needle really well, but you're trying to spread that local anesthetic between the maxilla and the sphenoid in the pterygopalatine fossa. 2 to 4 ml should be adequate. Here's actual performance of the block. So this is a suprazygomatic approach. We're anesthetizing. The patient's obviously under sedation for this. So preferably either under general anesthesia or moderate deep sedation.
Don't speak too soon.
A lot of the OR noises that you're used to. So we're going close to the cheek. And I showed you the video of the ultrasound. So we're about 3 to 5 centimeters, depth when it comes to the angles. It's a modified out-of-plane approach. Glossopharyngeal nerve blocks are very uncommonly performed. Good indications would be tonsillectomy, peritonsillar abscess, triple Ps, and basic tongue biopsies. Volumes are very low for these, so just be mindful that you'll be using very little volume. So here's a video of it. So you have sternocleidomastoid. Then you have a muscle underneath, which is the splenius capitis. And between the splenius, right posterior to it, is your glossopharyngeal nerve. So you might want to scan around this area in the neck, pretty high up. Find those two muscles and go posterior to the splenius capitis. Sorry. So positioning is that way. You're coming cephalad to caudad. Here's sternocleidomastoid. Splenius capitis is not very well visualized, but we'll get to that in a few seconds. So we're being very careful because we have a lot of vasculature, carotid artery, and we're using a local anesthetic. So thick fascia is giving us some resistance in injecting. So we slowly advancing the needle. So now you see the splenius capitis, and then you can see the nerve block under the splenius capitis. So you have two muscles, sternocleidomastoid, splenius capitis, and you could do that with 1 to 3 ml of local anesthetic. Superficial cervical plexus block, I'm sure some of you have already performed these. The good indication is your carotid endarterectomies, thyroidectomies, or right for the clavicle, along with the interscalene, could be beneficial. Even cervical lymph node excision. If you're doing an awake internal jugular venous cannulation, this might be a good block to perform. Here's a video of this. You have sternocleidomastoid, you're just going posterior to it. It's an easy block to perform. I'm probably using a 27 gauge hypodermic needle because you don't need much of a big needle here. So the medicine is spreading along the posterior border of the sternocleidomastoid. We're somewhere in the middle of the sternocleidomastoid, halfway through the neck, where most of the nerves are in. Yeah, so some of it went in the muscle, as you can see. So those things happen, as we know, in real life, just part of what we do. Ganglion block. Stellar ganglion block is a good block to just build on your skills of regional anesthesia if you're interested. I think in the OR, the number one reason I would probably use is treatment-resistant ventricular tachycardia, or in the ICU, acute limb ischemia. If there is a thrombus, and then you might want to help that. Also, if patients have hiccups, that might be helpful postoperatively if needed. We're just going to quickly go over the stellar ganglion. Again, it's a combination of inferior cervical ganglion when it fuses with the first thoracic ganglion, also known as stellar ganglion. It's anterior to the transverse process C7 first rib and the longus coli muscle. So we'll show you the longus coli muscle. This is the longus coli muscle. Basically, an injection under the carotid artery, if I want to simplify it. Here's an anatomical depiction of the longus coli. Here's the stellar ganglion. And if you look, there is the C7 does not have an anterior tubercle rec, as you know. That's a good landmark to identify when you're doing this. Here's a couple of videos of the stellar ganglion block. So 5 to 7 ml of local anesthetic is adequate. Sometimes it can be very challenging. As you can see, this is one of the blocks which was very vascular. So obviously, extreme caution and repeated aspirations are mandatory in this. So that block in particular, I almost aborted, but we just did it anyway. So we do have the world's largest collection of stellar ganglion blocks. If you're interested in browsing different anatomies, different complexity, all you have to do is scan this QR code or go on youtube.com/@stellar ganglion blocks. So that's all the society's collection of close to 60 different anatomical variations of stellar ganglion blocks. Upper extremity, we have 2 nerve blocks we're going to talk about. Suprascapular, we're talking about the posterior suprascapular, and the axillary nerve block, which is not the brachial plexus. As you know, it's a great block when combined with axillary nerve block to cover your shoulder and fractures and shoulder surgeries. Suprascapular nerve from the superior trunk of brachial plexus covers 70% of the shoulder, as you can see. Also covers the posterior superior aspect of the shoulder, so all the ports, if you're doing a shoulder scope, gets covered, glenohumeral joint and the AC joint as well. Here's the scanning. You're just scanning the scapula here. You have the supraspinatus on top, sorry, here, and then you have trapezius on top of the supraspinatus. So you have a suprascapular notch with a pulsating artery, transverse ligaments right here. Depiction of how you can do, I mean, depending on the side and your dexterity, you could do autoplane and in-plane. It's a very safe block to do autoplane because all you're going to hit is the bony part of the scapula. Here's a patient sitting up and getting a suprascapular nerve block. Nerve, a good nerve along the neck of the humerus comes from the posterior part of brachial plexus. As I said, it's usually in combination with the suprascapular you would do. There's a couple of ways of approaching a patient's lateral decubitus. You can do cephalad to caudate or caudate to cephalad, depending on the side of the patient, your dexterity, and your right hand or left hander. So you're looking for deltoid teres minor and a neurovascular bundle, which includes the circumflex humeral artery and the axillary nerve. So here's a depiction. You can do autoplane or in-plane. I've done both. Or cephalad or caudate. You can come proximal to distal, distal to proximal. Here's a cephalad to caudate approach. This is the caudal to cephalad approach. You will see this could be a little more challenging when it comes to, this is obviously the caudal cephalad neck of the so it looks like that. You visualize these really difficult in this one. Chest wall blocks, intercostal nerve blocks. I know you probably do a lot of chest wall surgeries, abdominal surgeries. These could be a good adjuvants in your toolbox. Good indication for intercostal nerve blocks. Obviously, rib fractures are obvious indications. Rib plating, breast surgeries, thoracotomies, VATS, any dermatological coverage, pretty much thoracoabdominal, you can choose to do one level or multi-level. The nerve anatomy, obviously, we know there's 3 intercostal muscles, the separations, external intercostal, inner intercostal, innermost intercostal. So the nerve is between those two. As I always mention, there's not 12 intercostal nerves, there's only 11 intercostal nerves. The 12th nerve is called a subcostal nerve. Before we know what level to block, we need to know how to count the ribs. On an X-ray, we can count the ribs, but how about ultrasound? So you can count the ribs either from cephalad to caudate or caudate to cephalad. Here's a depiction of how we can scan and find the rib counts. So let's say I want to do an intercostal block at T4, I need to know the 4th rib. So here's the count here. You have rib 1, you have rib 2, rib 3, rib 4. So you just count down and then figure out what rib. How about counting from below? First thing you want to see is T12. No pleura. Pleura is here. 11. 10. Keep scanning up. There's no pleura, and it's a drop. Absence of pleura with a drop of muscle. So another video of similar caudate to cephalad, pleura, rib, 11th, 10th, 9th, go back. So anatomy-wise, you have pleura, rib. Those are the things to consider. Here's a intercostal nerve block depiction. We can also do intercostal cryoneurolysis. You can freeze these nerves for long term because thoracotomy pain is obviously chronic most of the time, so give you long-term relief. Here's how the ice ball is going to look like. This is different devices that you can do cryoneurolysis with. This is the iOera and this is the EpiMed, which you can do cryoneurolysis with. Here's a 95-year-old with rib fractures. Obviously, very good indication for cryoneurolysis because the block's going to last a day, 2, 3. max. What about day 4, day 5, day 6? How many catheters are you going to leave? So we would just, cryo that 6th and 7th intercostal nerves. Subcostal nerve block. Again, subcostal nerve blocks is an uncommon procedure. It's basically reserved for 12th resection of Spigelian hernia, flank hernia. This is where we're looking at, there's no pleura after the 12th rib, there's a drop off, and you have erector spinae muscles. A lot of the times when you do a 12th rib, 12th subcostal nerve block, you will have a bulge in the flank, and it's common in just one of the patients that you may have a pseudo hernia for about a day, which resolves on its own. Abdominal pelvic blocks. You've heard of ilioinguinal genitofemoral, I think, as well as pudendal nerve blocks. Ilioinguinal nerve blocks, good for your hernia, appendectomy if it's open, even C-sections instead of doing a tap block with a huge volume. I would say it's easier to do this and use a lower volume because patient's already getting epidural local anesthetic. How much volume can I put in? Those are the things, groin and scrotal surgeries as well. As you all know, ilioinguinal nerve comes from L1, senses the skin and muscles of lower abdominal wall, labia majoris, and scrotum. Here's the probe position. You're placing it on the ASIS and then facing the umbilicus. Here's a depiction you could do in plane or out of plane, depending on your comfort levels, how you want to approach it. You have the same as a tap plane, but you're going in the same tap plane, but you're using a very low volume, very precise block. Here's the ilioinguinal nerve block in plane. So patient supine, becoming lateral to medial. So blocks are pretty quick most of the time once you get fast out within. So here's an out of plane approach for so you have external oblique, internal oblique transabdominis. Here's the hyperechoic. So I'm coming out of plane, you see tissue displacement of the needle. Once we're there, it's literally like a tap, but we're just using lower volumes and being very precise in targeting the nerves. You can cryoneuralize as well, as this inguinal hernia can be very painful, so you can always freeze the ilioinguinal nerves if you feel like. Genitofemoral nerve blocks, again, if done in combination with ilioinguinal, seem to be very beneficial for patients. So if somebody's getting inguinal hernia repair, I would do ilioinguinal and genitofemoral together because that's all the area that the patient's going to get surgery. And testicular surgeries, varicocelectomy, hydrocelectomy, all these can be good indications for genitofemoral nerve blocks. Genitofemoral nerve, unlike ilioinguinal, comes from L1 and L2. As you can see, anterior scrotum and cremaster muscles are the more common innervation for the genitofemoral nerve. Ultrasound guided genitofemoral is very easy. Once you know how to do a femoral nerve block, you're going to find the femoral artery. That's everybody can do. Then move the probe a little cephalad and turn 90 degrees. You'll find the external iliac artery and vein. Then you scan and find the spermatic cord around ligament of the uterus. Nerve is usually not visible. I usually combine ultrasound with nerve stimulation for this particular nerve block, just to get a sensory feedback from the patients if they're awake. A low volume block, so that should take care of it. Here's how the femoral artery, external, iliac arteries appear in the spermatic cord. So you can either inject in and around the spermatic cord. Here's the nerve scanning. So we're at the femoral artery vein, femoral nerve. I'm just going a little cephalad and turning the probe around 90 degrees. As you can see, the transition from femoral artery into the iliacs. Very easy to identify. If you look at the left side of the screen, you will see most likely the spermatic cord, which I'll scan and say, bring it into the picture and then block using a nerve stimulator needle. Here's the genitofemoral nerve block and out of plane. Here's our spermatic cord. So we just come out of plane. Here's the needle, just tissue displacement with out of plane approach. So if you're not using a nerve stimulator, I would just put 5 to 7 cc and say, hey, I'm going to just let it be numb because you can't see the nerve. So subtle expansion of the local anesthetic here. We'll do an in-plane approach. Same thing, you see the external iliacs, artery and vein, pulsing. Here's your spermatic cord and this. They're coming in plane. You can use a 27 gauge needle because things are very shallow in skinnier patients, but you can use a regular nerve block needle as well and try. But again, you're very far from these vessels. I wouldn't be scared about doing these nerve blocks. Just fill that spermatic cord around ligament of the uterus. So some local anesthetic that should usually take care of it. Pudendal nerve blocks, again, if you're in labor and delivery, episiotomy, laceration repair, again, probably the gynecologist obstetrician would be a good person to do that. Vulvar biopsies, excision of Bartholin cyst might be a good indication. Primarily, anorectal surgery would be my go-to, like hemorrhoidectomies, anal fissure surgeries are very painful. Perineal abscesses, again, you have to be careful with the abscess as where the abscess is and whether you can put a needle or not. So this is something to be cautious about when you're using this for penile and scrotal procedures are also indicated, like penile prosthesis and stuff, but they're less commonly used. Pudendal nerve, as you know, it comes from the sacral ventral rami S2, S3, S4. It has 3 branches and supplies a lot of structures in the pelvis. Here's the sciatic nerve and the pudendal nerve. Here's the anatomy. The nerve usually lies medial to the artery in this area where we do the pudendal nerve block between the sacrospinous, this is the spine of ischial spine, and sacrotuberous ligament, ischial tuberosity in the sacrum. So here's the outer plane approach of the pudendal nerve. You have gluteus maximus, ischial spine, neurovascular bundle. You can see a little pulsation, the needle slowly coming out of plane. We're using a nerve stimulator here. So almost always we use nerve stimulator in combination with the ultrasound for the pudendal nerve block. Outer plane seems to be the easier, most reliable way of doing pudendal nerve blocks. We also described the ischiorectal approach. Let's say you have a very large buttock or there's a lot of scarring from previous surgery. Your ultrasound images either poor or not visualized much. So you can literally do an ischiorectal approach with a nerve stimulator needle and a nerve stimulator. I'm going to show you some videos of how that's done. Patient is prone. Another one much easier. So it's really fast if you're like, find ischial tuberosity, go medial, numb the skin. Four centimeters in, and then you have an inner rectal twitch. That's just 100% proof that you're at the pudendal nerve, and the twitch disappears when we inject. Lateral cutaneous nerve block. I think some of them, probably you guys already probably do them. Good indication for skin grafts. Procedures involving anterolateral thigh, like biopsies, burn debridements, wound care. Some of the providers also do it for total hip replacements, orthoplasties, and so origin L2, L3 divides into anterior posterior divisions. Main muscles to remember is the sartorius and the tensor fascial lata. So you basically are going scanning lateral, find this nerve between the sartorius here, tensor fascial lata, and then anesthetize it. Here's a video of the you have femoral artery sartorius, which is going scanning lateral. Here's tensor fascial lata. Here's the nerve in this little enclosed subcutaneous compartment. So I'm using a 27 gauge again. You can use 27 gauge. You can use a regular nerve block needle doesn't really matter how you do it. Just doing out in plane, you could do out of plane as well. A smaller volume, 5 cc, or if you don't know where the nerve is, maybe 10 cc if you need to. The small volumes will suffice. Labat sciatic nerve block, again, like you would probably do the subgluteal, you would do mid-thigh, you would do popliteal sciatic, but when would you use Labat sciatic? In Labat sciatic, you're using a nerve stimulator, only no ultrasound. Supraproximal femur fractures, along with the femoral nerve block. If there's a hamstring origin repair, it's pretty high up, so you want to get that before the nerves, because the sciatic nerve gives intramuscular branches to the hamstring, and a lot of these branches originate above the hamstring insertion and have to be taken there out. Let's say you have a high above knee amputation postoperatively where there's dressing, nobody did block preoperatively, and you have a lot of dressing which you can't get through. Then like, yeah, I'll just do a Labat sciatic. Total hip arthroplasty, there's a posterior approach. You can add that along with your peng block or whatever your facility does. If you want complete anesthesia in patients who you don't want to put them to sleep, the lumbar plexus block plus Labat sciatic gives you complete anesthesia of the lower limb. So this is a skill you might need once a year, but a very important skill to have. Here's a demonstration of the Labat sciatic. Operative nerve block. I think this is a block that you might want to consider using, especially as you know, bladder surgery, spinal anesthetic, they might have the operative reflex intact. About the amputation, the patient complains of medial pain, medial thigh pain. And it's also an adjunct for knee surgery or hip surgery if patients are having that medial deep pain. Operative nerves comes from L2, L3, L4. There are two divisions, anterior and posterior division. So this is the position, usually, frog leg. So you're inside of the femoral crease. You're looking for three muscles. They call it Alabama, ductus longus, brevis, and magnus. The nerves are in between the fascial plane between those two anterior and posterior divisions. Here is an operative nerve block in combination with a nerve stimulator. So there's few more blocks, and we've done pretty much innervation of the foot. As you already know, there's 5 nerves. The main nerves we're going to target today would be the superficial peroneal, which supplies the top of the foot, and the sural, which is along the outside. Tibial is a great block. Again, you can do either tibial above the ankle before it becomes medial nerves. Here's the superficial peroneal block, the lower third of the leg. I'm just using a 27 gauge needle. Again, you can use a regular nerve needle or 27 gauge needle. Here's a needle straight. Here's another one. This nerve, as you can see, is pretty large. It's usually because there might be a small neuroma in this. Usually the superficial peroneal nerves are not this big, but if they have chronic pain and there's acute on chronic pain, you can see these chronic nerves which are really large between the fibularis brevis and externus digitorum longus. Sural nerve is a great block right behind the calf. The only thing that you can see about the gastroc is your short saphenous vein and the sural nerve. Easy to place the probe, easy to do the nerve block, just about gastroc and soleus. Here's an out-of-plane approach. Here's a little pocket of the area. This is gastroc. So you just have to fill this pocket with local anesthetic. Once you start filling, a lot of times the nerve just comes and floats in. So you can see the nerve here. That was it. And just a reminder again, this is a QR code for our ultrasound and regional anesthesia workshops. We do about 2 to 4 of them every year. Go on to ultrasoundexperts.org for more details on the agenda, registration, all those. We're the only society who does the cryoneurolysis workshop. So if you're interested in expanding your skills in cryoneurolysis, either post-operatively or beyond, you have 2 workshops to attend in June and October. They all happen in beautiful Tampa. The second annual scientific meeting on post-surgical pain is scheduled to be held on December 5th and 6th. It's a weekend in Tampa, so we would love for you to join us as we can discuss more, talk more. And there's 2 live workshops, which is fully included with registrations. One workshop is ultrasound regional anesthesia workshop on Saturday, and the second workshop is on Sunday, which is cryoneurolysis for post-surgical pain. I'm sure that would probably pick some interest for you. Last but not the least, collaborators are welcome. So if you're interested in contributing to the society, please reach out to us, info@postsurgical pain. We're actively looking for social media ambassadors, audio, video content creators, like we've shown you many videos today, board members, research and publication liaisons, and membership committee chairs. With this, I would end the presentation. If you have any questions, please put them in the chat box so I can answer them to the best of my knowledge. Let's take a look at the chat box. If there's no questions in the next minute or so, we would say good night. But thank you for joining us. We appreciate your time. Looks like, Nick, we have no questions. I guess
I'm seeing one.
Oh, there's Q&A. Okay. Okay. Do you typically perform the pudendal nerve block pre or post? It all depends on the surgeon's preference and the OR schedule. I would like to perform all the blocks pre-operatively, along with the sedation. Post-operatively will be more difficult because I'm putting them prone. They're probably asleep. So preferred that we do it pre-operatively. It says, thank you, Christy Bailon. You're welcome, Christy. And there's 4, there's settings for nerve stimulation. So as you know, nerve stimulation, depending on the nerve, if I'm looking for a sensory stimulus, I'm at 0.5 to 1 milliamperes. But if I want a motor stimulation like pudendal, I want a 2-3 milliamperes. So that would be the stimulation. But if the nerve is visible, I don't need a nerve stimulation. So it's more like a precision work, wherein pudendal nerve is now visible, genitofemoral is now visible, then I would use nerve stimulation. That answers David McLeod's question. Let's start it. Looks like we've come to the end of it. Thank you, everybody, for joining us. We hope we'll see you at one of the workshops or the annual conference soon. Thank you, Nick. Good night.